So for child factors to consider, there's four really main categories. The first one is the diagnosis. There are specific interventions for different diagnoses. There's also different interventions when there's comorbid diagnoses, meaning there's more than one diagnosis going on for one individual. So interventions for kids with autism would be different than kids with ADHD. There'll be some overlap, but there'll be some key differences in each of them. So something to be really mindful of is you want to make sure if your child does have a diagnosis, you want to make sure you do an intervention that is research-based to support that diagnosis. And if your child doesn't have a diagnosis, getting a diagnosis would help you point you in the direction of what interventions to get. The second thing to consider is the child's age. You want to make sure whatever intervention you're getting is delivered in an age-appropriate way, because how you would treat a 3-year-old with anxiety, for example, would be very different than how you would treat a 8-year-old or a 16-year-old with anxiety. So the different age of the child would mean different interventions. It also means sometimes your child could age out of one intervention and into another intervention. And so that's something to be mindful about and to be open-minded about when that time comes. The next part to consider is the ability level. What is my child able to do? This is a little bit more relevant when you're looking at a child with special needs, because oftentimes there may be things that are going on with the child that make certain things more challenging. For example, if a child had autism and they are very aggressive toward other people, no group intervention would currently be appropriate for them. That would be above their ability level. They wouldn't be able to meaningfully participate in a group setting. So those types of interventions would not be beneficial, even if the intervention is going to target another sort of deficit or concern you have about your child. The next thing to consider is the child's motivation and interest. Every human is more likely to want to do things that they're motivated for or that they're interested in. And that includes therapy. Because there are a lot of different therapeutic options available, your child is going to enjoy some more than others, and they may be more interested or motivated for one type of therapy over another. You never want to force your child to go to therapy, and you want to find a therapy intervention that your child has some enjoyment for. Keep in mind, a lot of therapies for children are what's considered skill-based, meaning they're going to learn skills they don't currently have. So it is going to be sometimes a little bit stressful or challenging for them to learn new skills. And 1 or 2 upsetting sessions should not be a reason to discontinue the intervention. But if it's a long-standing pattern, a couple of weeks, maybe a month, and the kid is just very upset about going, they're not interested in going, they even maybe tell you they don't like it and they tell you why, that is something to take into consideration and look for other interventions that would be more aligned with their motivation and their interest. The next thing that we need to talk about is family factors. So this is also very important because whenever there's a child, the family is automatically involved. The child can't drive themselves to treatment. The child can't, be responsible for remembering all of their appointments. So we have to consider the family as well. The first thing that comes to mind is cost. There are a variety of different costs associated with every type of therapy or intervention that is available. And it ranges from essentially government funded, which is typically free, all the way to private pay, which comes at varying cost levels. So that is something to consider. In the initial stage of the treatment, you want to be very clear about what the family's financial responsibility is, as well as the length of treatment in order to get meaningful results. Because you don't want to invest money, as well as time when you think about cost, but that's more of a commitment. So you don't want to invest money in an intervention if you can't see the intervention to the end, meaning that you're not going to be able to commit to completing what we call like a treatment episode, which is what's expected in order to see meaningful results. The next thing to consider is commitment. So how often or frequently do you have to do this therapy? How much time is involved? How far, if it's outside the home, how far is it from the house? And at what time of the day? Sometimes with traffic patterns, it can make a big difference going somewhere at 4 o'clock versus 6 o'clock. So you want to be mindful of the commitment it's going to take for the family, how often they're going to have to attend sessions, how much time is involved in going to and from. Also, too, like what type of involvement. So the next point is the family going to have to do. Is this a drop and pick up intervention? Drop the kiddo off and come back in an hour. Is it something where you need to be a part of the treatment and be there for the entire duration? Is it a hybrid where sometimes it's with the child, sometimes it's with the parent, sometimes it's with the child and the parent? What sort of time commitment and money commitment outside of the treatment delivered to your child is involved? That's something that you need to make sure that you're clear up front. So again, you don't invest into something that isn't going to work for you. The last thing to consider is your own personal cultural values. Therapy is a very personal experience, and whatever lens the therapy is going through, there's inherent sort of protocols, and there's like a mechanism, a way of doing the therapy. And sometimes different cultures are not receptive to that method. And sometimes you may want to fight against it or try to get them to adapt to your cultural views. Sometimes adaptations can be made and the treatment or intervention can still be really effective. Other times, some of the sort of requests or things that you want different about the treatment isn't really obtainable or feasible, and then either treatment's going to end prematurely, or you're going to be not getting the results you want and essentially getting frustrated and aggravated over the intervention. So it's important to express any really important cultural values that may come into play. This may be more prevalent in a home-based service where people are coming to your home. Like, for example, you may be uncomfortable with someone's gender in your home, especially if you're by yourself with your child. So those are things to keep in mind and discuss up front before you get involved in any sort of treatment. So the next thing that is really important is how therapy should be proven effective through research. There are a lot of claims that something works, and you really cannot be sure of that unless there is research that backs it up. I love the quote by Arthur Conan Doyle, who is the author of the popular Sherlock Holmes novels. It is a capital mistake to theorize before one has data. So essentially meaning just going into something, thinking it's going to be great, and really having no data that supports your claim. Someone made a flashy presentation, someone just made promises that they can do this work, and really there's no data, there's no proof that it's effective. Sometimes parents feel a little stressed to find a really good intervention or treatment, so they keep searching, and when they find one that seems too good to be true, sometimes it is. And if there's no research to support it, I really caution you trying to do that. One, it can end up just not being effective for your child, so you wasted time and money. Two, it could also be harmful for your child because there's no research that shows what happens when the intervention is delivered or what doesn't happen when intervention is given. So when you have research, when you look at this wheel here, you can see there's a lot of different things that go into research that's really important. The systematic approach is doing something the same way each time that is proven to be effective. And the research is going to be delivered in that sort of cadence. So it's always going to be similar. It's always going to be delivered with integrity, and that's going to help get results. Research proves that things are objective and unbiased. So the way that research is conducted is they kind of control for variables that could affect the results. So that way they're able to say, this intervention works really well for kids with ADHD. We've done, studies with 500 individuals with ADHD, and 80% of them have gotten the results. What that means, though, is potentially only because of ADHD were in the sample, meaning they can only talk about results for kids with ADHD. doesn't necessarily mean it's kids with ADHD and anxiety or ADHD and autism. So that's something to keep in mind when you look at objectivity and unbiasedness. It works, but it works only for the population they're explicitly stating it works for. Empirical evidence just means that they have used statistical measures to determine the significance of the research. It's not just 2 + 2 = 4. It's very advanced sort of mathematical arrangements that really prove that it's a causation or it's a correlation, meaning that this intervention caused this results, or a correlation, these things change when this intervention was implemented. Replicability, or the bottom right, the orange one, essentially means that anyone can pick up the research methods and essentially do the research to replicate the results. So it's kind of like a checks and balance system, meaning that just the researcher, can say, we've got these wonderful results. And then to prove that the researcher wasn't falsifying data, other researchers will do the same research and get, hopefully, very similar results. So that would go into replicability, being able to replicate the treatment, the research to prove the intervention is effective. Transparency is very similar. Everything that's done in a research study is publicly available. Sometimes it's a little jargony because it's written in scientific journals, but technically all the information about what went into the research is available, and you can ask for it and you can get it. If you ask for it, you don't get it, that's a major red flag. And if you ask for it and it doesn't sound like anything they're telling you, then that's also a red flag. Research always has logical and critical thinking embedded into it. Essentially, people have really thought about how could we get meaningful results for the research, and it's usually not just one person. It often goes to what's called an institutional review board, meaning that an outside board of professors or other practitioners in the field are looking over the research questions and the methodology. One, making sure that the research is going to be delivered in a safe and humane way to the participants, as well as thinking critically, does this have a chance? Do we think this is going to be really helpful and meaningful research? Peer review essentially means that once it's done, people read through it, they mull over the data, they ensure that what the conclusions drawn makes sense. Also, a lot of times with research, they cite other research that also supports their claim. So essentially, they're bringing in all the data points together, not just from their research, but from other research as well. And the iterative process is essentially a fancy way of saying that it gets repeated, the process, over and over and over again to come to conclusions and firm results. The next thing to consider when you're looking at any intervention or therapy is the provider qualifications. Providers do have what's called a standard of care, meaning all eye doctors are going to do very similar things, and that's like the standard of care. All medical doctors do very similar things. You go see them, standard of care. Same thing for mental health providers or providers that do other interventions for children is each discipline, so OTs, speech, ABA providers, mental health professionals, they all have a standard of care. They all have a policy and procedure that they have to go through. They all have similar sort of goals and missions that they're trying to obtain. And there's essentially like a toolkit, arsenal, if you would, of techniques and interventions that they use as part of the therapy in order to get effective results. So while each person may do it a little bit differently or may take a different sequence, essentially there's going to be the standard. There's going to be people doing similar things. The other thing to keep in consideration is accountability. So most of the time, people that work in the helping arts or helping sciences are accountable to some sort of certification or government board. In California, psychologists are registered by the Board of Psychology. All the master's level clinicians are governed by the Board of Behavioral Science. BCBAs, who are the supervisors and kind of the spearhead the ABA treatments, are accountable to the Behavior Analytics Certification Board if they're licensed in that state. Additionally, the licensing board for the state, speech paths, OTs, everyone that is registered to the state or registered to a certification board has accountability. So what that means is they have to behave in an ethical way and follow the ethical code for whatever their certification is in. Additionally, they have to follow all the rules of the state if it's a license. So there's specific rules and laws that govern their practice, and they're held accountable. If you're ever getting an intervention or a therapy that you feel is not helpful, or something went terribly, horribly wrong, and there's been some harm done to the individual, you can make a claim against the certification board or the licensing board that you were harmed or that the therapist did something that they were not supposed to do. And the certification board or the licensing board will investigate and potentially take action against the individual. It can be something as just like probation, where another licensed or credential provider will have to like kind of supervise and watch their work. It can be sanctions, so they would have to pay damages, so money to potentially the families or to the state. And it can also be license or certification revocation or surrender, meaning you are no longer allowed to practice and you lose your license. The accountability piece ensures that the provider that you're working with is going to do ethical care. And you want to make sure that you have someone that's going to be accountable to another governing agency. So that way they don't do anything, or it's less likely anyone is at risk of making an ethical violation. But essentially, it's less likely that those would happen when you have a profession with accountability. And the last thing is the provider's reputation. I caution people to rely on Google reviews and things of that nature. Sometimes it's only the people that were unhappy about things say things. And also too, a lot of providers, because of confidentiality, are not allowed to respond on any of those review sites. So you're really only getting one side of the story. The best way to determine someone's reputation is to ask other similar providers about the provider you want to see. Because providers know providers, and providers know who's good and who's not good. We have that professional lens, we have the clinical judgment. We really are able to determine if the provider typically acts within good faith and typically behaves in an ethical fashion. And we also know if kids are, if the kids are getting better under their care. I know for myself, I had a handful of different practitioners that I refer to because I know they have a really good reputation. And a lot of times what ends up happening is you create what's called like a treatment team, especially for a child with, let's say, autism, where they're going to have a need to have different therapies at some point in their life. And then everyone works together, even though they don't work in the same location or they don't work in the same discipline. Everyone refers to everyone else, and they all know that the quality of care is going to be equivalent across all the different providers. But again, the best way to judge someone's reputation is to ask other providers that you trust if they've heard of them, what they've heard of them. I would not hold things they say on the internet, to the highest standard, because again, providers cannot respond because that would be a breach of confidentiality, and that's unethical for us to breach confidentiality. So you want to make sure that you do your due diligence and look into what their reputation could be. So now we're going to talk a little bit about 5 different therapies. The first one being ABA, and then we'll go to HFS, then we'll do play therapy, occupational therapy, and speech therapy. I could talk hours about probably all of the therapies, so we don't have time to do that. But I will give a broad strokes overview of them, and then later on, when there's question and answer time, if there's any specific questions that I didn't answer, I'd be more than happy, if I know the answer, to be willing to share that with you. So applied behavior analysis has been around the longest. We were looking at interventions for children with autism. It's been around since the 1970s. And with that, there is the most research support that exists currently for autism is applied behavior analysis, or ABA for short. Doesn't mean it's the only thing, and we're going to talk about other treatments in this talk where there is research that supports their effectiveness. But ABA is the longest one. They have the most empirical support. It's still considered the gold standard in the treatment for autism. So that is something to keep in mind. With that being said, in the United States, there is mandated insurance coverage for every single insurance plan, whether it be self-funded, a commercial plan, or one of the state-funded plans, federally or state-funded. So Medicare, Medi-Cal, Medicaid, whatever state care plan is used for autism. Meaning if your child has autism, any insurance policy in the United States must cover applied behavior analysis. Now, there can be requirements such as having a psychological evaluation that proves a diagnosis of autism in order to get coverage. There could also be limitations on how many hours that you're able to get or how much, in a year. So they're not all created equal in terms of like the amount of therapy you get, but you do get coverage in the United States with autism. Not an expert globally, but I know that there are some countries as well that also provide insurance coverage for autism. So if you're interested in finding that out, a quick Google search should be able to answer that question. One of the hallmarks of ABA programming is that it is completely individualized. ABA treatment always starts with an initial treatment plan, typically something called the functional behavior assessment. That is where a BCBA typically will meet with the parents and get a really good understanding of the parents' concerns, as well as a lot of different background information. The concerns would be any challenging behavior that would be occurring and any skills that they would like their child to do that their child is currently not doing. So ABA inherently is a skill building intervention or therapy, as well as a challenging behavior reduction intervention or therapy. So they both skills go up, challenging behavior goes down. With ABA, there's a main component of what we call replacement behaviors, meaning that we can never just make something go away. We always have to replace it with something more socially appropriate. So a lot of the therapy, there's multiple things happening at one time. As we're teaching new skills, we're inadvertently, we call it punishing, which is like reducing challenging behavior. And we do it in a very systematic way, and we do it over and over and over again. ABA gets delivered in larger quantities, multiple hours a day, multiple days a week, and through a lot of the repetitive practice, these new skills are formed and the challenge behavior gets reduced. In ABA, there's a big hallmark is reinforcement. So when kids do things that we really want to encourage them to keep doing, we provide reinforcement, which sometimes is as simple as verbal praise, sometimes it's more complex, like giving them something they like. But either way, we always use reinforcement to increase skills. And then we use a term called punishment to decrease skills, which is essentially withholding reinforcement for when you don't want to reinforce the behavior. For ABA therapy, it is based on the 4 functions. So behavior analysts and those that do ABA do believe that there are only 4 functions or 4 reasons behavior occurs. One is for attention, one is for escape or avoiding of non-preferred or aversive things. One is for access to tangible, they want something they can touch. And then last is like a sensory-seeking behavior. They're doing something because they like how it feels. A main component of ABA, and it's actually the analysis part, the second A in ABA, is database decisions. ABA practitioners take data on everything. We take data on how frequently challenging behavior occurs or what the duration of the challenging behavior is. Sometimes we do more complex calculations with the rate per hour, or we do rating scales to rate severity of challenging behavior, but we are always taking data on challenging behavior. And we're always taking data on replacement behaviors, which are the new skills or the new behaviors that we're teaching. And then we make we take data on all of the goals that are typically made, and we get our goals as part of that initial assessment, where we are giving standardized measures such as adaptive behavior measures, and then like sometimes the VB map or the AFLS, which is a functional living skills. Sorry, word escaping. Functional living skills like assessments, and then and the VB map is based on verbal behavior. Essentially, they're research-based interventions. I'm sorry, assessments that help us figure out the goals to target in treatment. And then to do ABA, each practitioner does have highly specialized education and training. So all BCBAs have at minimum a master's. Their masters have to include coursework in behavior analytic principles and theories. Currently, there is a master's in applied behavior analysis. That is relatively new, probably within the last 10 years. So a lot of other similar degrees, such as master's in psychology or master's in education, would also be eligible to become a BCBA if they did behavior analytic coursework kind of post-masters, essentially. And now currently sometimes embedded in a master's program. But either way, BCBAs are master level credentialed individuals with not only graduate school training, but they also have to go through about 2,200 supervised hours from a BCBA in order to be eligible for the exam and then pass the exam. And then the direct line staff, there is frontline credentials, what they're called. Typically, they're 40-hour like sort of classroom or web-based training, some sort of competency, like at the demonstrate skills, and then they take an exam to get the credential. And then some of the credentials just get renewed annually when they get supervision and training in the field, and or they take continuing education units to renew their credentials. But either way, everyone that works in ABA, there is highly specialized education training that has to occur. There are many different types of ABA. So even though it's the same science, the way that it's delivered can be different. I don't think I'm gonna have time to go through all of them, so I'll just talk about two. Discrete child training, that's the green bubble at the top, is probably one of the most known about treatments for ABA. It is the original one that Dr. Lobos himself did in the 1970s. And this is the one that breaks down skills into very small steps. And it essentially, we teach every skill in the smallest step possible in a sequence. So then we can make sure that they know all steps of the skill. And then going on the other side of that, natural environment teaching integrates the skill development into everyday routines and activities. So this is like the least structured ABA approach, where everything occurs within naturally occurring learning opportunities. And different types of learners or students or kids would do better with different types of ABA modality. Typically, learners with more support needs and would need more of a discrete child training, and those with like lower support needs can probably learn a natural environment training or NET, which is the salmon colored bubble on the bottom right. So another treatment that is really great for kids with autism as well as kids with ADHD is the HFS cognitive training system. And this is one of the newer interventions that has really great research. So again, I mentioned research being such an important component when you're looking at interventions. What's really cool about the HFS cognitive training system is that it is completely personalized. So there's like an intake assessment. So you find out kind of the needs of the individual. And then there's the AI supported intervention system. So a real person, they call them HFS coaches, who also go through a comprehensive training program in order to understand how to deliver the intervention. So they can't do it on their own until they went through and completed and mastered the training component. They do the intake. They enter it into the computer system, the AI program spits out essentially like a treatment plan. And then after every session, the coach gives feedback to the system. So they take data and they give feedback on the learner's performance. And then the system adapts the treatment. So after every session, the intervention is getting tweaked, which is really great. This is research supported for kids 5 to essentially 18. And what's really cool about the HFS cognitive training system is it's a strength-based intervention. So it builds on the child's strengths. And it also works on, because it's doing things the kid's already good at. So in our brain, we have neural pathways. And our neural pathways have to talk to each other. It's kind of like highways in our brain. And we can do everything we know how to do because we have a neural pathway connecting neurons in our brain. So the HFS system uses what's called neuroplasticity in order to kind of speed up those highways. And if there's a pothole in the neural pathway, it like repairs that pothole. There are no holes in our brain, but just for like the analogy, essentially it's going to strengthen these neural pathways through neuroplasticity. What's really great is it targets attention, sensory processing, and social emotional challenges. Those are two big things that are common not only because of the autism, but also because of the ADHD. The data that has been collected by Cognitive Leap Solutions through their research supports improvement in cognition, motor, language, and social emotional skills in 40 sessions. 40 sessions is wonderful. That is a very short time to get very meaningful results. The therapy takes place one-to-one, usually in person, or there is a telehealth option. And it includes music listening therapy, as well as skill-based exercise training. All sessions are an hour. The listening therapy, if the kids are able, they wear like a headset that's bone conducting. So it's not like a headset that covers the ears. The music goes right into your brain through bone conduction. And then during that time, they do the 6 skill exercises. There's also a really cool relationship component with HFS. The coach is a real person, and they're with the kiddo. They're helping and praising and supporting the kiddo and doing new skills. They're really happy and excited when the kiddo does something good. If something's hard, they give them encouragement. So it's not just a computer. It is a real life human that is also interacting to have that therapeutic value. How Leap is able to do the HFS cognitive training system, you can go to their website to learn more about it. They have some centers in SoCal and NorCal, and they also are able to do things online as well. The HFS cycle, so how the therapy actually works is it starts with connection. So the coach and the child make a connection. All good therapies start with rapport. You need to have to have a good relationship. The activities are play-based. Kids learn through play. So through play-based learning, they're practicing, doing the skills. That's the next bullet, practice. It is step-by-step. So they do skills over and over again, and they do them to mastery. So, if they didn't quite get something, on session 4, they're probably going to try it again in session 5. Maybe tweak a little bit, but there's a practice component where they're going to go over and do it again. Then we get mastery, so they're able to prove that they can do that skill. And then they get the recognition, which is essentially them recognizing their growth and them realizing what they were able to do and kind of validating the whole experience, where they're able to be like, wow, like I couldn't do this activity, 3 weeks ago, and now I can. So it's something very positive for them, and that is why this is a strength-based approach. This slide talks about the research findings. The light green is before the HFS program, and then the darker green is the after HFS programming. And anything that has a little asterisk or star means that they got what's called clinically significant results in the research. So the ones that you can see are also in blue on the right. So after 40 sessions, they were able to get significant improvements in emotion, attention and focus, impulsivity, and hyperactivity went down. Concepts of time went up, so understanding that better. Planning, organization also went up, better planning, better organization, and then language and comprehension. So understanding language and expressing language. So comprehension, understanding, expression, putting it back out also has significant changes after 40 sessions. And this was also presented at Stanford, and the full research is available if anyone wanted it. The next intervention we talk about is play therapy. So play therapy is also evidence and research-based. There is an association of play therapists. There's a play therapy journal. So there's the whole journal is just dedicated to how play therapy helps kids. So lots of evidence, lots of research to support its effectiveness. What's really cool about play therapy is there are specific play therapy, both interventions and therapies, based on the diagnosis of the child. There is something called play therapy, which is a play therapy approach for children with autism. There is play-based cognitive behavioral therapy, which is really great for depression, anxiety, as well as ADHD. There is theraplay therapy, which is a humanistic touch-based therapy that's really great as a family intervention, and the list goes on and on. So there really is a lot of different ways to do play therapy, tailored specifically to the child's needs and to the therapeutic modality, whether it be individual, group, or family. And then play therapy is always done by a mental health professional. So that's typically someone who's licensed as a psychologist or marriage and family therapist, or sometimes they're called licensed clinical professional counselors. And other states have other terms, like licensed professional counselor is in other states. But essentially, they are a mental health professional. They've gone through grad school for a mental health degree, and typically they are licensed by the state in which they work in. And then people learn play therapy, so students and people obtaining licensure will work underneath licensed providers in order to learn how to do play therapy. So only mental health professionals can do play therapy. So I love this quote by Mr. Rogers, about play therapy. So as adults, we sometimes think that play is just frivolous and not important. That is not true. Play is often talked as if it were a relief from serious learning. But for children, play is serious learning. Play is how they communicate. Play is how they view the world. And that through play, they can work out anything that's going on in their life. So some benefits of play therapy is they get increased problem solving, language development occurs, they learn how to regulate or self-control themselves, regulate their emotions, manage their behaviors. They get better social development, they can learn empathy and compassion and how to socialize with others. Mathematical thinking can also be increased through play therapy. They get curious about math and they get curious about learning. And then in play, what's really cool, they can also try out new roles. Through imaginative play, they can pretend to be somebody else, or they can pretend to be a different family member. Which helps with perspective taking. So play therapy really is quite beneficial for children with lots of diagnoses: ADHD, autism, depression, anxiety, OCD, things of that nature. It can help with pretty much anything that is diagnosable. So another really popular therapy is occupational therapy. Occupational therapy is a separate discipline than what we talked about thus far. There are occupational therapists, and they are trained to do just occupational therapy. And they are trained at the master's level as well as the doctoral level. Like a lot of the other research we talked about today, other interventions we talked about today, it is evidence-based and research-based. There are journals of occupational therapy. There are sort of categories in occupational therapy where there's extra research, such as sensory integration or feeding and swallowing. It's a whole separate paradigm in occupational therapy. So very largely research, very evidence-based. When we think of occupational therapy, one way to think about it is it teaches the adaptive skills, or what skills would you need to have an occupation and function in the real world. So it's very heavy on skill building, on teaching those adaptive skills, having individuals learn what they need to learn to have successful daily lives. Another big component of occupational therapy is a sensory regulation component. Most OTs have gyms, which to the common observer would just look like a jungle gym of some sort, like a playground, but it's way more than that. The way that kids move their bodies and how they shake and how they fall and how they look at things and how they smell things. All of those sensory components, an occupational therapist is obsessing and observing, and they're making tweaks to the therapy to help them regulate in a way that's going to keep their bodies calm and focused. So there's a huge sensory regulation piece, and it may look like they're swinging in a chair, but they are doing way more than that. So I found this awesome quote by a Boston Marathon bombing survivor who was a typically functioning individual named Jessica Kingsley. And then she had to go to occupational therapy in order to learn how to take care of herself again, because she was a victim in a bombing. And I love that this quote that she put out. Occupational therapy is where science, compassion, creativity, and compassion collides. So I guess she said compassion twice. Um, but either way, I think that it's something to keep in mind, all of the things that occupational therapy can work on. So they work on all the motor skills. So fine motor, gross motor, visual motor, motor planning. Visual motor is how you see the world. Motor planning is how you're moving your body. And then fine and gross motor are small little skills or large body movements. They help with executive functioning, which is fancy way to say planning and organization. They can help with academic skills, handwriting, cutting, things of those natures that would be used in school. They do most of their therapy through play-based methods as well. It can be social. There's group OT, which would mean there's more than one individual there at the same time. And then they work on sensory processing or regulating the sensory system. The last therapy we're going to talk about today is speech therapy. Again, like the others, evidence and research based. There's journals and speech therapy. Speech therapists are master level credentials. They have to go through rigorous training and licensure to become a speech therapist. One of the best things to think about for speech therapy is just how essential communication is for living. We communicate all day long. And sometimes people just think, well, speech therapy means like your voice. There's been a lot of advancements in speech therapy, and sometimes verbal language is not capable for sometimes our kiddos with autism. So they also really help find out how your child can communicate and then uses methods to teach them how to communicate successfully. And maybe it's with an ACC device, or maybe it's with a picture system. There's lots of different options. And because of how wonderful technology is, a lot of times now, all these ACC devices just end up on like a smartphone or a tablet. So it makes it a lot more accessible than trying to buy a device and carry it around. It's on devices that are already getting carried around. And then what's really cool about speech therapy is emotional regulation can also be taught through speech therapy with very specific intervention called functional communication, teaching individuals when they get frustrated or upset how to communicate in a way that's going to be effective and easy for them to do in that moment to get their emotional regulation, to help them with emotional regulation. So I found another quote. I really like quotes. I think it helps frame things. So Janice Light was a Penn State distinguished professor, and she said communication is the essence of human life. Again, we do it all day, every day. So because of that, speech therapy definitely enhances communication. It improves reading and literary skills. So verbal language or understanding speech goes hand in hand with reading and reading comprehension. It helps increase self-esteem and independence. Imagine if you couldn't communicate. You would have to rely on somebody else for all of your needs. So being able to get words, you are going to get an increase in independence. You are going to feel better about yourself because you're not reliant on others to guess what you need. You're able to express yourself and be able to get what you want and get what you need. And then it's a cornerstone of social skills. People, when there's more than one person in the room, you don't just sit quietly in isolation. You interact with each other. So speech therapy will help develop social skills, whether they be verbal or nonverbal. So I put together this comparison chart looking at all the different interventions. So along the top, you have the 5 interventions that we talked about: ABA, HFS, play therapy, OT, and speech therapy. We have the main area of focus. So what does each one look at and develop? And I did essentially talk about the main areas for each of them, so I'm not going to spend too much time. I'll just make a note about play therapy. I put reducing pathology in the chart. I didn't say that earlier. That's just a different way of saying working on like a mental health diagnosis. For service intensity, you can see that there's some variations between each of the therapies. I did mention that ABA is the most intensive service. It is often 5 times a week, 2 to 4 hours each time. As kids go on in ABA, the frequency and intensity decreases, but it's usually always multiple times a week for multiple hours a day. HFS is 2 times a week for an hour. The other 3 are typically an hour, 1 time a week for an hour. Earlier, I talked about family factors to consider. So when I think about family involvement, I was thinking, how much does like the parents or siblings even have to do in order to be successful in this therapy? So ABA and speech.
Right now?
Huh?
Go take a shower right now.
You want to take a shower? Yeah, go ahead.
Like, do I do it right now?
Yeah, sure. Why not?
Okay. Sorry, I thought that was a question for me. Anyway, so family involvement. ABA and speech are high because the families have to often do a lot of the work in the therapy as well. For ABA, there's always parent training, so the parents have to meet with the provider to learn what's going on, and then they're expected to implement the intervention when the intervention is not happening by the trained provider, as well as they're often, especially if it's home-based, someone has to be home with the child. So you can't just leave your child and the ABA provider in your home by themselves. And then speech therapy is high because the parents are expected to be right there learning how the speech therapist is working with their child and essentially continue to work on speech therapy throughout the rest of the time and day until they come back next week. OT is medium. So in OT, typically parents will observe OT sessions. They might have some activities to practice at home. They might not. Parents are more involved in a more specialized training, such as speeding or swallowing. Like that's something that the parents want to practice at home during meal times, but it's not the same level of involvement as the other two. And then for HFS and play therapy, it's pretty low family involvement. You'll do a parent check-in here or there, but you essentially drop the kid off. They do the intervention and you take them home. For location of services, it's pretty self-explanatory, kind of the standard locations where services are held. I put telehealth in parentheses because I strongly believe that in-person therapies are still better delivered than telehealth, but that doesn't mean that's the only way to get things. And sometimes telehealth is the only option if you're in a rural area or you can't find a provider close to you that works. So a lot of it can be due through telehealth, but if possible, you do want to do in-person work. For OT, I did not put telehealth because they do require often specialized like gym equipment. So it's very unlikely that you would have specialized OT gym equipment at your house. However, the OT could suggest you buy some items that are more home friendly in order to work on things with your child. For cost, there are some variations in cost. For ABA, like I said earlier, it is mandated insurance coverage for autism only. So if you have ADHD only, even though ABA would help, insurance will not cover it. And then the regional center, if you're in the state of California, does have programs available for ABA coverage. And it ranges from fully funded programs, meaning the regional center pays everything, to cost bearing assistance where they help pay what insurance doesn't pay. And then regional centers have 2 funding options in California. One is vendorization, and then one is the self-determination program. But either way, you have to be involved in a regional center to access that. All the other ones, essentially private pay, obviously, and ABA private pay too, but it's very expensive. But private pay and insurance does cover for all the for play therapy, OT, and speech. For HFS, there's 2 funding options. So right now it's a private pay option, but they're hoping through more research support to eventually get insurance coverage for it in the future. And then there is a program in the state of California called the Self-Determination Program, or SDP, and it's through the regional centers, and they're able to essentially give the family money for them to then use to pay for the services. So it's kind of like an HSA account or FSA account. You get an allotment of money and you're able to use it on approved things. So HFS is an approved treatment or intervention for the self-determination program. And then I put on the very bottom, it looks a little cut off on my screen. I hope it's not cut off on your screen, but the expected gains. As I mentioned earlier, HFS gets really quick gains, 40 sessions, which is 20 weeks if you go twice a week. ABA, you often see gains in about 6 months. And then for play therapy, OT, and speech, you start to get gains every about 3 to 6 months. Want to be clear, it doesn't mean your child is cured or clearly fixed in those times. It just means that you see meaningful change as a result of the therapy. And then this is the last slide, and then we'll go into question and answers. You need to avoid any unrealistic claims or fads. If I put mom blogs on there, parents love to share their experiences, both good and bad. Please be mindful if some parent said that their kid did really good with gardening therapy. One, we don't know if there was any other things going on other than gardening therapy. And it could have just been what's called idiosyncratic. It could have just been like a fluke. It's not proven by research and it's not replicable. So you don't want to get your hopes up if you're reading blogs about these fad therapies and how it helped the child. Be wary of testimonial only sort of claims. While, yes, people who got value out of services or interventions may leave a testimonial, but typically providers will only share good testimonials, right? No one shares negative testimonials. So you're really not getting a balanced view of the service. So be very wary if they're really laying on thick, look at all our testimonials as a way of proving that their therapy works. With that being said, cures. Unfortunately, a lot of mental health disorders, autism included, can never be cured. Individuals can be taught skills that mask and teach them how to be essentially less autistic in public, and be able to learn how to live with autism and make decisions and choices that are going to help them be successful and do well in life. But technically, it's never a cure. The autism is always going to be there. It's just going to be at a minimal level where it doesn't interfere or impact in their life in a significant way. Be mindful if someone does have any qualifications. Like, that's a huge red flag. So ask, what are your qualifications? How long have you been doing this? Did you go to school for this? What training program did you do? You want to know that they're qualified to do the job. If they get nervous or apprehensive or defensive about you asking about their qualifications, avoid them. That is a red flag. And then there's an old saying, too good to be true. If it really does sound too good to be true, it unfortunately probably is too good to be true. There's always going to be an intervention that doesn't work for everyone. That's just how humans are. It's just impossible to figure out something that works 100% of the time for everyone. So if something does sound too good to be true, it probably is. So that brings me to the end of the planned talk.